Lesson 2. How to recognize symptoms and early warning signs of relapse. After the first episode, the life of the person with schizophrenia and of the whole family never returns to its former shape. From that moment on, one of the most important elements of care is careful observation of day-to-day changes, because schizophrenia is not a static illness. It has periods of stability, but it also has moments when things start to wobble, often very subtly, barely noticeably. This is precisely the stage at which the caregiver's role becomes crucial. Most relapses of schizophrenia do not appear suddenly from one day to the next. Before the positive symptoms, hallucinations, delusions, disorganization become visible, for a few days or sometimes weeks small, inconspicuous signals appear in the person's behavior. These are tiny details that are easy to dismiss: slightly shorter sleep, more tension than usual, loss of interest in everyday matters, subtle absent-mindedness, irritability, excessive listening to surrounding sounds. To a layperson they may seem trivial. To a caregiver, they should be the first alarm. This is why psychiatric manuals emphasize that the caregiver is the most important observer of the ill person, often more effective than the psychiatrist, who sees the patient only for a few minutes every few weeks. It is the caregiver who knows the person's habits, daily rhythm, typical behaviors, facial expressions, tone of voice and reactions. They know them so well that they are able to notice even millimeter-sized deviations from the norm, and it is precisely these deviations that are the most valuable diagnostic information. Early recognition of an approaching relapse can literally change the course of the illness. Quite often it is enough to adjust the medication dose, modify the daily schedule, arrange a prompt consultation with the psychiatrist, or provide a few days of a calmer environment to stop the process before it develops into a full episode. Clinical studies show that more than 70% of relapses can be halted if the warning signs are noticed early enough. This means less suffering for the person, less stress for the family, and often avoiding hospitalization. In this lesson you will therefore learn to look at your loved one a bit as if they were speaking two languages at once, the conscious language and the language of symptoms. You will learn to recognize when words, gestures, or emotions start to move beyond their usual range. You will learn to notice not so much dramatic changes as those quiet flickers of destabilization that precede a crisis. This knowledge is not meant to burden or frighten you. It is meant to give you a safety tool for the person and for yourself. Over time you will see that observation is not constant anxious watching whether something is happening, but calm companionship in which you know what a normal rhythm looks like, and you notice when it begins to shift slightly. Lesson 2 is the heart of the entire program for caregivers. This is where you learn to prevent rather than merely react. This is where you acquire skills that have the greatest impact on the person's health, on the family's stability, and on your own sense of safety. Positive symptoms: how to recognize that something is coming. Positive symptoms, that is, delusions, hallucinations, and disorganized thinking, do not appear suddenly in full force. Before the person's condition deteriorates sharply, you can usually notice small cracks in their behavior which, to a trained eye, are early warning signs. This is the phase psychiatry calls the prodromal period, the time preceding an episode. For the caregiver, this period is crucial because by responding early, it is often possible to prevent the development of full-blown symptoms. One of the first signs is a change in how the person responds to their surroundings. When auditory hallucinations begin, they start listening more intently to ordinary sounds. Suddenly they stop mid-sentence, turn their head towards an empty corner as if trying to pick up something very subtle. Their eyes may make quick movements, as if registering invisible stimuli. Quiet muttering under the breath may also appear, a sign that the person is beginning to respond to inner voices or to hold a conversation that no one else can see. Another worrying sign is growing mistrust towards those close to them. The person may start hiding their phone, checking who is behind the door, locking themselves in their room, or commenting on ordinary household noises in ways that suggest they are giving them new meaning. If they previously trusted the caregiver and suddenly become suspicious of them, this is a sign that delusional thoughts, most often of a persecutory nature, are beginning to develop. It is also worth paying attention to language. The person may begin to speak in a more enigmatic, metaphorical, or coded way. Sometimes they talk about random events as if those events had a hidden message. They may suddenly claim that the TV is blinking in a strange way, that a passerby said something with their eyes, or that the music in a shop is trying to warn them. For the caregiver, such comments are a quiet signal that the person's mind is beginning to interpret the world differently than usual. One of the most characteristic harbingers is change in facial expression and muscle tension. The person may have a blank, distant gaze or, conversely, an overly intense stare, as if they were scanning their surroundings. This is often accompanied by shoulder tension, slightly raised eyebrows, and moments of freezing, as if they were drifting off in thought for a moment. All these signals, subtle to an outsider yet visible to a caregiver, indicate that the person's mind is starting to lose its ability to filter stimuli properly. This is the moment when any intervention is most effective. It is not yet a time for panic or dramatizing. It is a time for observation and gentle support, providing a calm environment, monitoring sleep, making sure medication is taken regularly, and having attentive conversations that allow you to assess how much their perception of reality has changed. The earlier the caregiver notices these signals, the greater the chance that the approaching episode will be prevented or at least softened. This is why it is so important to learn the person by heart, so that you can notice even the smallest change. In schizophrenia, symptoms do not arrive out of the blue. They always knock first, quietly, gently. The caregiver's task is to learn to hear that knock. Negative symptoms, a slow withdrawal from life. The negative symptoms of schizophrenia are much more subtle than hallucinations or delusions. They do not attract attention through drama. On the contrary, they develop quietly, slowly, almost imperceptibly. For the caregiver, they can be particularly misleading because from the outside they look like laziness, discouragement, bad will, or even just a bit of a low mood. Yet they are one of the most persistent elements of the illness and often the first sign that psychological stability is beginning to crack. The most visible change is the disappearance of life energy. A person who until recently was functioning relatively normally suddenly begins to lose initiative. They stop doing small chores, do not reply to messages, avoid conversations, do not engage in activities that previously gave them pleasure. This is not a lack of will, It is a biological inability to act, caused by disturbances in the brain's motivational systems. Another signal is neglect of hygiene and daily routines. The person may take less care of their body, clothes, and surroundings. Their sleep pattern changes. Sometimes they lie in bed for long periods without actually resting. To the caregiver, this may look like carelessness, but in reality it is the result of reduced psychomotor drive. At this stage, the person's brain works like a drained battery that no longer has the power to start even the simplest function. In social relationships, negative symptoms show up as emotional withdrawal. The person stops reacting with facial expressions, speaks less, answers in short sentences, often almost mechanically. This is not indifference, it is the brain's way of protecting itself from overload. Even an ordinary conversation can, at this stage, be too intense a stimulus. An important signal is also the slowing of thinking and action. The person takes longer to make decisions, has difficulty planning, carries out activities more slowly, and sometimes stops them halfway for no obvious reason. This is not laziness or lack of intelligence, it is a neurological disturbance affecting the brain's executive functions. For the caregiver, it is especially important to remember that negative symptoms are often the first sign of destabilization. They appear days or even weeks before hallucinations and delusions. They therefore require a lot of attentiveness. If the person begins to withdraw from life, loses energy, neglects hygiene, has difficulty concentrating or planning, this is not just a bad day, but a signal that their balance may be at risk. The worst thing a caregiver can do in such a situation is to interpret these behaviors as a lack of effort or manipulation. That approach only leads to conflict while the illness quietly progresses in the background. It is much more effective to look at these symptoms as signs of a tired brain that is working below its capacity. At this stage, the person needs more support, not less. They need simple, clear messages, a calm atmosphere, a clear daily structure, and help with everyday tasks. In a sense, negative symptoms are the dark side of schizophrenia, invisible to the outside world, yet extremely painful for the person. Recognizing them is one of the caregiver's most important skills, because they tell you more than anything else about what may be coming. Disorganization, the first cracks in logic and speech. Disorganized symptoms are one of the most confusing elements of schizophrenia because they resemble neither hallucinations nor withdrawal. At first glance, they can look like simple absent-mindedness, tiredness, depression, or even talkativeness or mild nervousness. In reality, they are very early and very important signs that the person's cognitive processes are starting to fall apart. For the caregiver, they are a warning signal that often appears before delusions or hallucinations develop. Disorganization mainly affects thinking, speech, and behavior. The person may start to speak in a way that is less logical and less coherent, often jumping from topic to topic. A normal conversation suddenly falls apart because one sentence no longer follows from another. Sometimes completely unrelated themes appear, what a psychiatrist would call incoherence. For the caregiver, this shows up as a feeling that they're talking, but it's not really clear about what, and you have to guess at the meaning. You may also notice strange chains of associations. The person does not answer the question they heard, but the question that formed in their own thoughts. They may latch onto a single word in a long statement and build an entire narrative around it, often completely detached from reality. Sometimes there is what could be called thinning of content. The person talks a lot, but says very little. Their speech resembles a flow of words that carry almost no information. Disorganized behavior is another key aspect. The person may start performing actions in an odd order, forget steps in simple tasks, begin many things at once and finish none of them. A simple task, like preparing breakfast, can suddenly become chaotic, slices of bread scattered around, the knife ends up in the fridge, the coffee is brewed 3 times, and the person stands still as if trying to decide what to do next. This is not a lack of intelligence or disregard for duties, it is the breakdown of the brain's executive functions. The caregiver may also notice disorganization of emotions. The person's reactions become mismatched, laughter at an inappropriate moment, sudden silence, irritation without cause, lack of an appropriate tone of voice. They are reacting more to internal impulses than to the real situation. The hardest moments for those around them are when the logical structure of speech cracks only for a second. From the outside it looks like a minor inconsistency, but in fact it is a sign that the mind is no longer connecting thoughts into a coherent whole. If the caregiver learns to catch these micro-signals, they can respond much earlier, before more serious symptoms appear. Disorganized symptoms are often a source of misunderstanding. A family that does not know what they mean interprets them as poor concentration, sloppiness, or even malice. The person, on the other hand, feels pressure, frustration, and shame because their inner world really is beginning to work differently, and they have no control over it. The caregiver's appropriate response is, above all, patience, observation, and reduction of stimuli, as well as promptly reporting these changes to the psychiatrist, because disorganization very often means that pharmacological stabilization is no longer sufficient. In practice, disorganized symptoms are among the most important for the caregiver because they appear early, are subtle, and do not always cause concern in others. Yet it is precisely these symptoms that say the most about the fact that the person's system is starting to lose coherence. Recognizing them makes it possible not only to stop a developing episode, but also to significantly reduce the person's suffering. Disturbances of affect. Disturbances of affect are one of the most complex and confusing aspects of schizophrenia. On the outside they can look like absence of feeling, coldness or indifference, or, at the other extreme, like explosiveness, irritability, and sudden, excessive reactions. In reality, they are the result of a deep disturbance in the brain's emotional systems, which in schizophrenia function in an unstable, weakened, or over-aroused way. For the caregiver, it is crucial to understand that the person's emotionality does not reflect their character, but is the result of the illness and of medication. In schizophrenia, the integration of signals from the limbic system, which is responsible for emotions, and the cortical areas, which are responsible for interpreting and controlling them, is disrupted. In practice, this means that the person may react in a way they themselves feel is inappropriate, but which they are unable to change. One of the most common symptoms is blunting of affect, a reduction in facial expression, tone of voice, and expressiveness. The person does not react enthusiastically to good news, does not show joy, and does not smile in situations where they once would have. This can be painful for the caregiver because it looks like distance or lack of love. In fact, the person feels emotions inside, but their body and nervous system cannot express them. It is not indifference, it is blocked expression. On the other hand, in phases of destabilization, affective outbursts may appear, sudden episodes of anger, crying, irritability, or a sense of threat that seem out of proportion to the situation. In practice, these are system overloads, moments when even a small external stimulus is processed as too intense. For those around them, this can be surprising and emotionally difficult. For the person, it is often a brief, uncontrolled surge after which they themselves feel discomfort and shame. It is also important to know that affective disturbances can fluctuate, blunting one day, irritability the next, complete indifference the following day. This variability arises because the person's neurochemical system is operating at an unstable level, reacting to stress, fatigue, lack of sleep, or changes in medication dose. Once the caregiver understands this dynamic, they stop interpreting emotional swings as deliberate behavior and see them instead as a symptom, not a character trait. The most common mistake families make is trying to explain the person's emotional reactions using logic. Yet with affective disturbances, logic does not work because the problem is not in the thoughts but in the biological mechanism of emotion itself. The person does not choose either the emptiness or the outburst. They happen, and their control over them is limited. The caregiver should respond in a calm, stabilizing and soothing way, avoiding attempts to work out who is right or who started it. Soft regulation works best, lowering one's voice, using short sentences, avoiding pressure, reducing stimuli, turning off the TV, closing the window, dimming the lights. Sometimes it is enough simply to be there, without judging, without speeding things up, and without demanding a response. Disturbances of affect are not a measure of who the person is. They do not say anything about their personality. They are a consequence of destabilized neurochemical balance. Understanding this is one of the most important steps a caregiver can take to protect the person from conflict, shame, and trauma. Changes in social behavior. Changes in social behavior are one of the most painful aspects of schizophrenia for families. A person who used to be sociable, warm, lively, and communicative suddenly begins to disappear from relationships. They stop calling, leave their room less often, avoid conversations, and sometimes shut themselves away in their own world. For the caregiver, this can be hard to understand and even harder to accept. Yet isolation in schizophrenia is not a choice, but a symptom. It results from biological and psychological changes that affect how the person experiences contact with others. One of the most important reasons for withdrawal is overload from social stimuli. The person's mind does not filter information the way a healthy mind does. An ordinary conversation, its pace, emotional tone, nuances, can be so intense that their nervous system begins to perceive it as noise or even threat. Even warm, kind words can be processed as pressure. This is why the person often chooses silence and solitude. Their stimuli are predictable and safe. A second reason for isolation is fear of being misunderstood. The person knows their way of thinking, speaking, and reacting has changed. They do not want to appear strange, different, or incoherent. Many people with schizophrenia say openly that they are afraid their relatives will notice their disorganization or difficulty concentrating. Solitude therefore becomes a way to protect themselves from shame. During periods of more severe symptoms, rituals and behaviors may also appear that to the caregiver look odd or illogical, checking doors several times, arranging objects in precise lines, prolonged hand washing, stubborn repetition of the same actions. This is not a whim or weirdness, it is an attempt to maintain at least minimal control over reality. When the inner world is breaking into chaotic fragments, a repetitive ritual gives the person at least an illusion of stability and relief. Changes in social behavior can also result from the disturbances in motivation and drive discussed under negative symptoms. Meeting anyone requires energy, preparation, cognitive effort, and emotional regulation. If the person's brain is running at reduced speed, even a simple conversation can seem like a task that is beyond their capacity. Isolation is therefore not a rejection of loved ones, it is a lack of strength to sustain contact. When the caregiver sees these changes, they may feel hurt or pushed away. This is natural, but it is very important not to interpret withdrawal as a lack of love. The person is not fleeing from people, they are fleeing from tension they cannot regulate. The best response is a calm, gentle presence that does not force contact but makes it possible. Allow the person to be nearby, even if they are silent, sit in another room or just listen. It is worth remembering that isolation can also be an early warning sign of relapse. If the person suddenly begins to spend most of the day alone, limits eye contact, avoids conversation, or becomes irritable with others, the caregiver should treat this as an alert. This is not behavior, it is a symptom. Understanding these changes is one of the key elements of caregiver competence. Isolation, silence, rituals, odd behaviors, all of these are logical from the person's point of view. They have no other way to cope with their inner chaos. When the caregiver is able to see and accept this, the relationship becomes less painful and the help they give becomes more effective. Fluctuations in biological rhythm. Fluctuations in biological rhythm are among the most important warning signs in schizophrenia, and at the same time among the most underrated. Caregivers often focus on what is visible: delusional statements, hallucinations, emotional outbursts. Meanwhile, the person's body starts sending subtle signals much earlier that the psyche is beginning to destabilize. And it sends them precisely through disturbances of sleep, appetite, and psychomotor activity. Sleep problems may appear suddenly or develop gradually. The person may sleep 12 to 14 hours a day, or, on the contrary, hardly sleep at all. Both states are equally worrying. Excessive sleepiness is often the brain's response to overload, an attempt to shut down from stimuli and inner chaos. Insomnia, on the other hand, is one of the earliest signs of an approaching psychotic episode, a signal that the nervous system is running at too high a speed and cannot calm down. Persistent insomnia lasting even one full night should be a serious alarm for the caregiver. Appetite works in a similar way. Sometimes it suddenly disappears. The person eats very little, forgets meals, ignores hunger, cannot tell when they last ate. At other times, appetite rises sharply. The person compulsively looks for food, especially sweet, fatty, highly processed foods. Eating disturbances may be a side effect of medication, but they can also result from mood fluctuations, anxiety, or misperception of signals coming from the body. For the caregiver, what matters is monitoring trends, not single behaviors. If something starts to change, it will often go unnoticed by the person themselves, but clearly visible to those around them. Psychomotor activation is another piece of the puzzle. The person may become overly restless, pace around the house without purpose, change position every few seconds, walk from wall to wall, make nervous hand movements. Or, conversely, they may sink into slowing, sit motionless for hours, stare at one point, move slowly, as if through thick air. Both states result from disturbances in neurotransmitter balance. They are biological signals that the body is struggling to maintain stability. The caregiver should know that changes in biological rhythms often appear before psychotic symptoms. They are like a quiet warning, something is happening. If the person suddenly starts eating differently, sleeping differently, moving differently, this is not a whim or a bad mood. It is information that the brain has begun to operate in a different mode. This moment, although worrying, is also an opportunity. If you react in time, you may prevent a more serious crisis. The most effective response at this stage is to create an environment that supports a return to equilibrium, calm lighting, quiet, fixed meal times, zero pressure, gentle reminders about hygiene, reduced stimulation. And above all, observation. If fluctuations in sleep and appetite last for several days, intensify or are accompanied by agitation or slowing, contact with the psychiatrist is necessary. The person's biological rhythm is one of the most sensitive barometers of their mental state. A caregiver who knows how to read it will almost always react before the symptoms become dramatic. How to respond to the first signs of relapse. When the first worrying changes begin to appear, shorter sleep, rising tension, strange associations, greater mistrust, withdrawal, chaotic speech, one thing is crucial: do not wait for it to pass on its own. In schizophrenia, relapses rarely pass on their own, they usually build up. The earlier you respond, the greater the chance that the crisis can be stopped or at least softened. The first step is to maintain outward calm. The person is already overloaded with their own experiences. If the caregiver reacts with panic, raised voice, or dramatizing, their tension will only increase. Speak more calmly than usual, more slowly, in shorter sentences. Avoid logical debates about whether something is real or not. At this stage, it is not about convincing the person, but about reducing stimuli and stress. The second step is to limit stimuli. Turn off the TV, lower the radio, reduce the number of people in the house if possible. Create a simple, predictable space, the same room, the same places for things, minimum noise. For the person's brain, excess stimuli are like extra weight on an already overloaded system. Sometimes simply simplifying the environment can reduce anxiety and tension. Another key element is non-judgmental observation. Note in your mind, or better yet, on paper, what is changing, how the person sleeps, how much they eat, what they say, how they behave, whether voices, strange beliefs or new fears have appeared. Pay attention to how long each change has been present and whether it is getting worse. This information will be very valuable to the psychiatrist. Instead of saying recently things are worse, you will be able to say, for 3 days they've hardly slept, for a week they've been saying someone is following them, for 2 days they've been very tense, locking the door and listening at it. It is also very important to check medication adherence. Many relapses start with neglect of pharmacotherapy. The person forgets doses, changes them on their own, or stops taking medication because they feel fine now. Ask calmly whether they are taking their medication as prescribed. Do not accuse, do not catch them out, do not raise your voice. The point is to get information, not to start a confrontation. If you suspect irregularities, note them down. The psychiatrist must know about this. At this stage, you can also try a gentle conversation about how they feel, but without arguing about the content of delusions. Instead of saying, "It's not true that someone is following you," you can say, "I can see you're scared. That must be very exhausting. What can I do to help you feel a little bit safer?" In this way, you do not reinforce the delusion, but you show the person that their emotions are being noticed. If the first signs are mild, it is worth arranging an earlier appointment with the psychiatrist as soon as possible, or at least seeking telephone advice. Describe the specific changes you have noticed. The doctor may suggest adjusting the dosage, temporarily adding a calming medication, or recommending closer observation. The sooner such a response occurs, the more likely it is that an acute crisis and hospitalization can be avoided. Important, at this stage, do not try to push the person into functioning as they did before. This is not the right time to demand more responsibilities, to deal with official matters, to take up work, or to have intense talks about the future. For a brain that is entering a phase of destabilization, every additional task can be another brick added to an already overloaded structure. When to contact a psychiatrist or call for help immediately. There are situations in which you must not wait or hope that tomorrow will be better. Professional guidelines are clear. Certain symptoms require immediate contact with a doctor, an emergency department, or even an ambulance. These are moments when the risk to the person's health and safety, or that of those around them, is high enough that delay can have serious consequences. First of all, severe sleep disturbances require immediate action. If the person has barely slept at all for 24 to 48 hours, is clearly agitated and chaotic, begins to speak incoherently, feels they have a mission or special role, or has intense delusions, this is an emergency. A brain that does not sleep very quickly loses the ability to distinguish reality from psychotic experiences. This is a typical beginning of an acute episode. Urgent contact with a psychiatrist is also necessary when marked persecutory or religious messianic delusions appear, in which the person feels compelled to act. I must protect someone, I must punish someone, I must do something, or something terrible will happen. The stronger the sense of mission, the greater the risk of unpredictable behavior. If agitation, increased energy, and lack of sleep are added to this, you have the classic picture of an alarm situation. An absolute red flag is suicidal thinking or behavior indicating readiness to self-harm. Any statement such as, "I don't want to live, everyone would be happier without me," this makes no sense, combined with specific plans or gestures, e.g. hoarding pills, talking about methods of ending one's life, requires immediate contact with a doctor or calling an ambulance. Here it is better to err on the side of caution than to regret having ignored the signals. Equally serious are situations in which the person shows aggression or unpredictable behavior towards others, threatening, shouting, throwing objects, trying to hit someone, saying they have to defend themselves against an imaginary enemy. Even if they have never harmed anyone before, in the presence of strong persecutory delusions, the sense of threat may be so intense that the nervous system chooses attack as a form of defense. In such a situation, physical safety is the priority. Sometimes intervention by medical services is necessary. Alarm signals also include sudden, radical changes in behavior that cannot be explained by everyday stress. The person suddenly leaves home at night and returns after many hours without any logical explanation, stands motionless in one place for a long time as if frozen, says they hear specific commands, starts hoarding strange objects, looks for signs, creates elaborate rituals, refuses food for fear of poisoning. These are all signs of an acute psychotic state or of a rapidly approaching episode. In such situations, the caregiver is not expected to cope alone. Your role is not to be a doctor, therapist, and rescuer all in one. Your role is to recognize that the situation has exceeded what can be handled at home and that outside help is needed. This is not a betrayal of the person or reporting on them, it is a way of protecting their health and life. A good practice is to agree in advance with the psychiatrist and the person themselves on a crisis plan, a list of symptoms that mean we call the doctor without discussion, phone numbers to use, and even a prepared sheet with the most important information, diagnosis, medications, doses, previous hospitalizations, that can be taken to hospital. Such a plan reduces stress in a crisis, because the caregiver knows what to do instead of having to improvise. The caregiver's early reaction to warning signs, and their courage in reaching out for external help when there is danger, are among the most important factors influencing the course of schizophrenia. They do not prevent all episodes, but they often mean that crises are shorter, milder, and less traumatic, both for the person and for their family. Summary: early recognition of schizophrenia symptoms is one of the caregiver's most important skills. It does not require medical knowledge or clinical experience, it requires attentiveness, calm, and a willingness to trust your own observations. Changes in sleep patterns, appetite, behavior, emotions, or thinking usually appear many days before a full relapse, which is why it is often the caregiver, rather than the person themselves, who notices the first signs of destabilization. In this lesson, you have learned to see these signs not as oddities, whims, or bad moods, but as early symptoms of illness that deserve attention and a response. The most important rule to remember is that you must not wait for symptoms to pass on their own. Schizophrenia is a cyclical illness, and when symptoms increase, the person's brain loses its ability to regulate its own stability. Your calm actions, reducing stimuli, observing carefully, gathering information, having gentle conversations, and making early contact with the psychiatrist can determine whether a crisis develops into a full psychotic episode or is stopped at an early stage. The caregiver's response is not just emotional support, it is a real element of treatment that has repeatedly reduced the number of hospitalizations and eased the course of the illness. At the same time, the caregiver should understand that there are moments when you must not act alone. lack of sleep for 24 to 48 hours, delusions with a sense of being driven to act, suicidal thoughts, marked aggression, panic and extreme agitation. These are situations that require immediate professional help. In such moments, your role is not to replace the psychiatrist, but to protect the person by ensuring they have rapid access to medical care. The knowledge you have gained in this lesson is the foundation on which you will build all further care. The better you understand the warning signs of relapse, the more you protect the person, and also yourself and the rest of the family, from the chaos, suffering, and helplessness that an untreated episode can bring. In the next lessons, you will gradually learn how to respond to specific behaviors, how to communicate safely, how to build a stable environment, and how to take care of yourself as a caregiver so that you do not burn out. Schizophrenia requires vigilance, but even more, it requires calm, knowledge, and gentleness. And all of that begins right here.